All right, we're all set. Well, thanks again for joining us. My name is Ellen Albrighton, and I'm a Senior Policy Analyst here at Families USA. And I have the distinct pleasure of getting to work on our Community Health Worker Sustainability Collaborative. As I'm sure all of you know, community health workers are incredibly powerful for their communities and for individuals. They can do an incredible job of improving people's health, of communities' health, of addressing healthcare disparities, and also of reducing costs to the healthcare system and to other systems as well. And even though we know that many of you who are CHWs don't go out every day thinking, man, I can't wait to save my hospital system $4 for every dollar that I put in, and aren't thinking ROI, that a lot of times the arguments that we need to make for people, whether it's our employers or someone at the state, someone in the Medicaid agency, ROI does matter. So we want to be able to give you a tool that can help you show just how effective community health workers are. And to do that, we're so thankful that we could have folks from the Center for Health Law and Economics at the University of Massachusetts Medical School with us today. We worked with them to develop this tool, one that focuses on impact of an asthma intervention and another on a diabetes intervention. And they're going to walk through how to use the tool today, so that this is really kind of a hands-on webinar. We hope that you've had the chance to download these tools from the Families USA website. If you haven't done so yet, that link is in the chat box, and I encourage you to do so now so you can follow along at home. So with us today, we have Katharine London, Anit Velez, and Jeremy Torish from the Center for Health Law and Economics, and I will turn it over to them to lead you through this tool.
Okay, so we're going to go ahead and jump right in. This is Katharine London at UMass Medical School, and I'm here with my colleague,
Anit Velez.
And also, your name?
Jeremy Torish.
And we're going to be walking you through these two tools that we've developed. If you've gone to the Families USA website, I would encourage you to go ahead and download the tools, the asthma tool and the diabetes tool, and you can follow along that way, and you can enter data as you go and see how it works. We'll also be showing it on our screen and walking it through that way, but I think it's probably more useful if you're working directly on the spreadsheet. I want to say thank you first to the Connecticut Health Foundation that has been funding us for a number of years to do various iterations of this tool in report form, and then to Families USA and funding from the Kresge Foundation to develop this interactive version of the tool. So just a little bit of background. So my background, I started out my career actually setting rates that the Massachusetts Medicaid program pays to healthcare providers, hospitals and physicians and so on. And then, did a number of positions in state government. And, whenever you start a new program in state government, you have to do a financial analysis and figure out, exactly what the cost is going to be and provide a good estimate of what the expected outcome is going to be, or you don't get approved for funding. And most of the time when we were doing this, there's a proposal to start a new program, and you don't know exactly what it's going to cost and what the outcomes are going to be because you haven't done it yet. And that's the situation we're in often with community health workers. People are trying to start a new program and need to have some evidence of what they think is going to happen to show their funders or the CFO in their organization or whoever they need to convince before they've done it. So our effort here was to try to put that together for you because private organizations often don't have the resources that government has, for putting together this kind of an analysis. And what we've done here is we've built entirely off of the evidence that's already out there in the world. Community health workers have been doing great work for a long, long time. There's decades of research that's been published in the U.S., and we wanted to take advantage of that and learn from it and build from it. There's also, all kinds of published data sets with data all over the place. None of it is, ever exactly what you want it to be. And so what we've done is we've pulled in evidence and data from various different sources and put it together to build these estimates. And we've done it in a way to try to, as I said, try to make this into the set of information that you'd want to put together. And the way this is built, you customize it, as little or as much as you want, and we'll talk through how to customize it. Really, all you have to do is go in and put in what state you're in and when you're planning to start, and you can just use all of our estimates and print whole workbook, and then it'll print every page, and you can go in and talk to somebody and say, hey, look, I have this long report with all of this data, look at this. Or if you have more of your own data, you can put it in and make it more customized to your own needs. So it's as customized as you want it to be, depending on how much data you have and how much time you have to go in and make those changes. I do want to be clear that, because we pulled in information from various sources, that can introduce error. These are estimates. It is the best evidence that we could find, the best data sources that we could find that are available right now. That doesn't mean they're perfect. If you go and implement an intervention, you may get different results. I mean, I can't actually guarantee this, but this is all I can say is that this is the best evidence that we were able to find. And we've done these two models for asthma and diabetes, and our report for Connecticut has a couple other models. And you'll see as you go through them, they look a little different from each other, that the evidence that's available is different, and that the tools we were able to find that other people had done that we were building from, they're different for these different models. So we'll go through this in a lot more detail, but just sort of to lay the groundwork. For asthma, there were pretty good studies that talked about the level of control before starting the intervention and after, and utilization, so emergency room visits, urgent care visits, hospitalizations for an intervention group and a control group, and we were able to assign costs based on healthcare cost databases to that utilization and do our analysis that way. It's important to keep in mind when you're talking about something like asthma, and these are interventions where people recruited kids into an asthma intervention based on their, what happened to them this year. So the children who have poorly controlled asthma and had a hospitalization or had an emergency visit in this year. Now, you know that asthma kind of goes up and down because a kid had a big flare this year and ended up in the hospital this year. Doesn't mean that they will next year. Even if you do nothing, they might not get sick next year. And so it's important to look at not just the difference between this year and last year and this year and next year, but also the difference between if you do a community health worker intervention versus the child just has usual care in their doctor's office, what's the difference? And that's how we measure the value added by the community health worker, the difference between usual care and the community health worker. For diabetes, we took a little bit of a different approach because the people who have been recruited into the diabetes intervention are adults and have had poorly controlled diabetes for a long period of time and aren't improving. And so the idea that the thought is that nothing's going to change without the intervention, so we've just looked at before the intervention and after. But also, we had very different data about diabetes. Diabetes control is measured in a pretty standard way by A1C levels, glycemic control. And because it's such a standard measure, we were fortunate that someone had done a study based on a huge data set of health plan data and actually measured the cost the full year cost of treating diabetes for people at different A1C levels. So we actually have a cost by A1C level, so we can look at, for a study where people are at, a high A1C level going in and a lower A1C level going out, we can assign a cost to the cost at baseline and then the cost after the intervention and measure the difference. So we're going to talk through this as we go through the tool, but you'll see that these things are quite different. And just one more sort of general topic that I wanted to hit. In general, for any intervention that you're doing, whether it's community health workers or any other public health intervention, there are people who are pushing to show that there's a positive return on investment, that your intervention is going to save more money than it costs. I think many of us would argue that it's a good thing to invest funds and show a positive health outcome, and if there are also medical savings, that's great. But to the extent that you're actually trying to show a positive return on investment, to save more than it costs, in order to do that, you would have to target your intervention to people who otherwise would cost more. So you would have to make an effort at the beginning to only include people who are likely to end up in the hospital, really, if they don't get the intervention, rather than providing the service to really anyone who needs it. So that's just sort of my overall introduction to this idea. So now we are going to go through this tool tab by tab. We're going to start with the asthma tool, and then we'll do diabetes next. So if you go through, so this first tab is just a cover sheet, and it gives you a place to enter your title and some background information so that when you print it, it looks great. Next tab, contents, and we will talk through each of these. But you'll see that the calculator tool helps you to estimate the caseload for each community health worker, a budget for your intervention. There are 2 sets of healthcare outcomes projections, medical cost savings, social return, which for asthma is measured in school days gained and caregiver days gained. And for diabetes, we look at, because the diabetes is adults and asthma is children, for diabetes, we look at days of work gained, financial return on investment, and then we've also listed some other quality measures. The next tab, let's see, the introduction. I think we've gone through this. We can go to the next one, the intervention. So in order to do this modeling, we had to make a lot of assumptions. So what we did was that we focused on successful interventions that are out there in the world where people have done great work over time. For pediatric asthma, King County in Washington State, that includes Seattle, has implemented this asthma home visiting program over a number of years, and they keep perfecting it. So every few years they make adjustments to try to target the intervention so that they're providing exactly the services that are needed to the kids who need it, and working on trying to target it so that it becomes more cost-effective over time. And so this model is based on one of their more recent program designs called Medicaid Healthy Homes. Go down a little bit. And this intervention included a series of home visits. It's described here, and this intervention has a little more detail. And you'll see throughout this, we've included the citations, so you can actually go back to the study and get more detail from King County directly. There's a lot of information on their websites, and I would strongly recommend, if you're going to do this, to go back and look at what they've done. But we've used some of this information from King County to identify the time required for a community health worker to do this work. so including the home visits, telephone calls, and the community health workers go to the home and they do a environmental assessment and look for asthma triggers in the home, and they can provide asthma mitigation materials in a kit, an environmental kit to families, and that could include things like mattress covers and pillow covers and cleaning supplies, pest mitigation supplies, that kind of thing. So we've included, so you'll see as we go through the caseload in the budget that it refers back to each of these things. Instructions is for you to look at later, so that for people who aren't on this webinar, get a little more detail about each of these tabs. Let's go ahead to caseload. Okay, so the way we have calculated caseload, or estimated, I should say, estimated caseload for each community health worker. If you can go down a little bit and look at section A. So it starts with looking at the total time that a community health worker would have available to spend on client work. So we're looking at total paid hours, and we're assuming a 40-hour work week, 52 weeks a year, and then we take off time for holidays and vacations, sick days. And you'll see throughout this, and then time off for meetings and then for training. And you'll see throughout this tool that the gray cells are what we've are the automatic calculations, and the pink cells are where you can make changes. So if you go into one of these cells, so if you want to say, okay, we don't do 13-page holidays, we only do, say, 10-page holidays, you can change it, and it'll calculate all the way through the whole spreadsheet. So all of these things are linked. If you make a change on this first caseload spreadsheet, it's going to follow through all of the different tabs, and the budget's the same. You'll see as you make these changes, they'll follow all the way through. So this first part is it's saying that this community health worker has 1,692 hours available for client work, and then if you go down to section B, we're estimating the amount of time required to actually provide the intervention. So starting with, how much time does it take to call people to say, so assuming that you're starting with, say, an asthma registry that has information about where you could identify children who have poorly controlled asthma and are at high risk because they had an emergency room visit in the last year or something like that. Your community health worker is going to get a list of families, and they'll need to call and engage and explain what this is and invite the family to participate. So that takes a little bit of time. And when we count this up, we're counting also the time for talking to families that say no, right? So you engage, and some people agree and a lot of people don't. And again, and also as you start doing the intervention, some families will drop out. So we're putting in the amount of time for each event. So we put in an average of 3 home visits per person per year. The full intervention is 4 visits, we would hope, but the average might be 3 if a number of families drop out. But again, you can make changes to this as you're doing your own estimates. The amount of time for a home visit, how much travel time it takes. Travel time will vary depending on whether you're in a city or a rural location, for example. How much time does it take to for whatever paperwork, follow-up they need to do after each visit. Phone calls, how many times will they call each family per year? Again, on average, averaging out the people who drop out, maybe some families get 6 and some get 2, and it averages to 4. And time in minutes for phone calls. So that gets you to the total hours required per participant. And if we go down to section C, so in this case we are saying that we were planning to hire 2 community health workers. That's the 2 in the pink box. You can change that. You'll see that in this spreadsheet, this 2 is going to carry all the way through. So we're having a budget for 2 community health workers. If you change it, go ahead. If you change the 2 to a 3, for example, you'll see that it'll pop up the number of participants. So let's keep it at 2 for now because it's a little easier to get your head around to start with. And this is saying that there's, given the assumptions above, that one community health worker could work with 95 participants who complete the intervention. But because we know a lot of people will not take up the intervention, a lot of people will drop out. If you go to section D, sort of working backwards from this 95 participants per community health worker, and there's rounding that comes into here. That's why the number comes out a little bit different. But we'd expect about 190, 191 people to complete the intervention with the two community health workers. But if you count for the people who are expected to drop out, so I'm working up from the bottom, you'd have to actually have 354 start for 190 to finish. And we'd expect you'd actually have to contact 590 patients in order for 354 to sign up and then 190 to finish. So, you'd have to look at how many kids you have on your registry who would fit the profile of high-risk asthma. If it's not 590, if you only have 200, you might start with one community health worker. If you only have 100, you might start with half a community health worker, a third of a community health worker, and have them do other things the rest of the time. So that's how to think about the caseload.
Katharine, we have a question, if I could just interject before we move on to the next tab. We've got a question from Debbie. She says, is it possible to change some of the components on this sheet in section B, for example, to include time spent to do an educational workshop or provide navigational support? And would these affect the estimates?
We didn't build that in, and that would have been a good idea. So, maybe we could add a blank slot for, time for other things and put it in. I think one thing, the easier thing to do actually would be if you go up to the top to section A, if you wanted to add more time for other activities, and it wouldn't show up as well as you want it to be, but like where it says hours per year for training, if you wanted to make that training and workshops or other activities instead of 40 hours per year, they're spending 200 hours per year for these various activities. It will flow through. But we could put in a line there for other activities that people could put in if you want. Okay. Good. Should we go ahead to budget?
Sounds great.
Writing myself a note. Okay, so then in budget, so this is laid out just kind of like your typical budget that you would normally submit for whatever reason to for a grant or any other kind of a funding thing. And we filled in values based on what we could find best information on. We put in salaries for a community health worker and a community health worker supervisor, which are based on national averages. But again, if salaries are higher or lower in your area, obviously you can go in and change those. We put in a fringe value. We had done a number of interviews with a number of different organizations that employ community health workers and got data from them on what was typical. So, this kind of fits with the costs that typically are incurred, but, again, your costs may differ and you can customize this as much as you want. So there's personnel at the top, there's fringe, travel. We included, a standard federal rate per mile. Some states have a state rate per mile that's different from this. We put in miles per month and per community health worker, right? Tolls, parking. So if if you're not covering tolls and parking, you can make those zero. So this is just kind of, we try to put in the kinds of things that you're likely to have in your budget. If you go down to supplies. The cost of an asthma kit, again, sort of depends on what your what your program is going to share and how much that costs, depending on what you're able to get, so you can adjust that. We assumed that there will be sort of a maximum set of a full kit, a full set of materials that a family could get, but that every family doesn't need everything. Some families might already have mattress covers from last year, for example, and don't need more, but they need more pest control supplies this year, that kind of thing. So that's what the next line there, that percent of participants who require a full kit. So you could just do an assumption of how many you think will need the full kit versus then it'll discount the cost of services of supplies for families that already have some supplies. And then just we put in, sort of standard supplies, office supplies, computers, cell phone. We think you should budget for a computer and the cell phone. We do not think that community health workers should have to use their own private cell phone for their job. So I hope that will be included in a budget. Training, we put in just standard costs for training, but again, that might vary based on your location. And a standard cost for facilities, so rent and electricity and whatever your facility costs are, that's what depends on your own organization. Indirect is the cost of other costs of the organization. So usually there's some funding that's collected that pays for the CEOs, a little bit of the CEO's salary and the CFO and the accountants and lawyers and whatnot is what that indirect percent is, and grants often tell you what percentage you can include there. And then going forward, so this budget is coming up with a budget of $196,000 for our 2 community health workers. We're working with what we had said, 191 people, right? So this is about $1,000 per person per year. And then in Section B, you can put in an inflation rate. We put in 3% so that the costs for the second year and the third year get inflated a little bit based on an expectation that costs will go up. So I'm not seeing any questions on budget, so I think I'm going to hand it over to Jeremy to go ahead and talk about outcomes. We're on outcomes, tab A.
Thank you, Catherine. So as she said, we've moved on to the Outcomes A tab. And what this table projects is really any reduction in healthcare utilization over the course of the intervention for those who do and do not participate. Now, specifically, the table calculates any reduction in the number of emergency room visits, urgent care clinic visits, and hospital-related visits, depending on whether someone does or does not participate in the intervention. So if we scroll down towards the bottom of the tab, starting at about row 24, we can see kind of the results of this tab. And this table really projects the benefits of implementing this asthma mitigation intervention based on findings from the Seattle-King County study that Catherine previously referenced. And now, as you can see, the target population figures are drawn from the caseload tab. Now, that's whatever you put in there, and they move to this tab and then throughout the rest of the tool. So if we go down to the results, you can see we have our measures: emergency department visits, urgent care clinic visits, and hospitalizations. One can see that based on intervention participation or non-participation, there are better results from participating in the intervention. For example, for emergency department visits, without the intervention, the decrease, which is typical of someone with asthma, as Catherine mentioned before reviewing the estimator tool, the decrease in emergency department visits is greater with intervention participation than without. And that's the same, but to a greater extent, with urgent care clinic visits and hospitalization, as you can see here. Now, to get these results.
Thank you. Jump.
Sure.
So, go up one just a little bit more. So, as Jeremy's pointing out, and as I mentioned before, that the findings are that if you had an emergency, if a kid has an emergency visit in the base year, a lot of kids don't have another emergency visit the next year. So that's what he's showing you, where this 338 emergency visits for our population of 192 kids in the base year, and it goes down. The difference between the control group and the intervention group is really small for emergency visits. It's much bigger for urgent care, and it's a little bigger for hospitalization. Although because hospitalizations are so expensive, that's actually where we're going to get the savings. But we'll talk about that in a minute. But this is all from Seattle King County's results. This is where we're showing you if you did exactly what King County did and got the same results, this is what it would look like.
Wonderful. So then to get these results in this bottom portion of the tab, we would go up to the top of the tab, as you can see. And so you have two options. You can either use published data from the King County study that's drawn from here, which will then move through to the bottom portion of the tab in the table we previously looked at. Or you can switch and enter your own data by going to the drop-down menu and picking My Own Data and entering information from your own asthma registry in these pink cells. So for example, we've switched to My Own Data, and if you put in emergency departments 2.5 visits, that will then change these figures down below.
So the way to think about this is if you have an asthma registry that tells you the utilization of your population, so you can pick out the kids who have poorly controlled asthma from your asthma registry, and you know that there was that group of kids, let's say you have 100 kids and they had 250 emergency visits, that would be an average of 2.5 visits per kid. And so that's what we're putting, you could put in your own data there. And if you don't have that baseline data, you can stick with that at the top of the screen here where it has that pink drop down. You can stick with using published data, or you can customize it by using your own data from your own registry.
Do we have any questions on this tab?
Not so far.
Wonderful. So let's move on to the second Outcomes tab, or the Outcomes B tab. So what this table projects is any improvement in health quality over the first year of intervention participation. So what we're looking at here is any reduction over the course of the intervention in the number of days every 2 weeks that an asthma rescue medication is used per person, the number of asthma symptom-free days per person every 2 weeks, and the number of patients whose asthma is well controlled over the course of 2 weeks. So again, let's scroll down towards the bottom of the tab to around row 24 again. And you can see the results in this table are again based on data drawn from the King County study. We again have our target population at baseline and year one drawn from the caseload tab. And we also are seeing the results of participating in the intervention for the previously mentioned outcome measures. Now, we can see that for each measure, there is a positive benefit for intervention participation. for example, let's see rescue medication use, days used in the past 2 weeks. You can see that there's a greater decrease in rescue medication use for those that participated in the intervention from 5 days to 2, as opposed to the people who did not participate from 5 days to 4. Then for symptom-free days in the past 2 weeks, you can see there's a greater increase in symptom-free days for those that participated in the intervention versus not. So from 7 to 12, and then 7 to 9 days. And then overall, for patients who have well-controlled asthma, you can see that for patients who participated in the intervention, again, there was a much greater increase in well-controlled days of asthma versus those that did not. From
number of patients.
Number
so we started with 0.
Right.
Because we only included kids in the study who had poorly controlled asthma. So out of the 192 kids, 86 would be expected to have well-controlled asthma with the intervention, and only 32 without. So that's a huge difference.
Yes, very big difference. So then to get these results, again, as in the previous tab, we would go up to the top portion. And again, we've made it possible for you all to either use published data, again, drawn from the King County study that's located here. So this data, if you choose to, would then populate throughout the rest of the tab.
Here, the gray part.
The gray part, yeah.
So rows 12 through 19?
Yeah. Or you can choose to use your own data by going up to the drop-down menu and choosing My Own Data and entering your own data in rows 7 through 9 here. So, for example, if we wanted to change the number of days every 2 weeks rescue medication is used from what's here, we could change it from 5 to, say, 10, and that would then change the results down in the bottom portion of the tab that we reviewed previously here. Do we have any questions on this tab?
Boy, the drop-down box does not appear in the Excel version I just downloaded. It just says published data, really. Huh. So if you go to column B, row 4, there should be, if you click there should be a little arrow to the right of the box, and you can click on the little arrow, and you should have a choice of My Own Data or published data. So if you, I don't know, it works on our version, so we'll check with you afterwards. I don't know if it's a problem with an old version of Excel maybe, but it should change.
Yeah, I downloaded one just before we started, and it seems to work. But we're happy to, we'll troubleshoot with you after, Debbie.
Okay, let's go ahead to medical costs.
Wonderful. All right, so we're now going to move on to the medical costs tab. So what this table projects is any change in direct medical costs resulting from implementing the community health worker intervention. Specifically, this table calculates any savings generated from fewer emergency room visits, inpatient hospital stays, or urgent care clinic visits related to asthma. This table uses data from a published study and a government agency to estimate the cost of providing these services, and then calculates any savings based on data from other portions of the tool. So let's scroll down again, as I've said the previous 2 times. Let's scroll down to the bottom portion of the tab, starting at about row 21 or 22. So again, as you can see here, we've projected out the costs for these 3 measures over a 3-year period. And again, this target population for each year, so each cohort, is drawn from the caseload tab. So again, this is another place where data is drawn from other portions of the estimator tool. So if we scroll down a little bit more and see just the measures, we can see that at baseline, so that's column B, the annual cost per person is higher for each of these measures. Now, as we move forward with each cohort per year, we can see that for both the participants with and without the intervention, there is a decrease. Now, for those without, as Katharine previously mentioned, that is just due to the nature of asthma and the treatment of it. But as we can see, when implementing the intervention, it does lead to greater cost savings for each of these categories, for emergency department visits, inpatient hospital visits, and urgent care clinic visits on a year-to-year basis. And if we continue down the tab, we can see the total costs per participant over the course of each year and at baseline. And as you can see, there are savings, great savings per participant through participation in the intervention. And if we scroll down a little bit farther, starting at about row 45, you can see the total medical costs for the target population of the cohort per year. And as one can see, there are even greater savings per cohort year over year. Now, again, to get these results, we would scroll back up to the top portion of the tab, and you have the option, and forgive me here, we'll try to size it well. So you have the option to choose the state that you're going to implement this in. And to do that, so for example, we have it at Connecticut now. To do that, you pick the drop-down and you can change the state. So let's change it to Hawaii, for example. And as you can see, various data points in the rest of the chart will change based on picking of that information. You can also decide to change the implementation year of the intervention. So right now we have it at 2020. Let's pick 2021, and that will also change certain data points in this tab.
If you go back down to the bottom, you can see that the numbers have changed.
The numbers have changed down at the bottom as well. So if we scroll back up to the top, as in the previous tabs, you also have the opportunity to either rely on published data from a published study and a government agency here, which would then give information for the rest of the tab. Or you can again enter your own data by going to the drop-down here in cell or row 5 and choosing My Own Data. This will allow you to enter data in the pink cells in rows 10 through 12, where you can enter average charge per visit for each local region, for the various measures we are looking at.
And we should note that, if you go in and change these, if you change the average charge for an emergency visit from $1,768 to, $2,500, it will only flow through if you make that change at the top to use My Own Data. That's sort of the signal to the spreadsheet to look to the My Own Data versus the published data. So you need to do both. You need to make that change to the drop down at the top, and then also make your change to the numbers.
Correct. Do we have any questions on this tab? Okay, so we're now going to move on to the social return tab. This table projects the number of missed school days and adult caregiver days disrupted by a child's asthma symptoms that can then be recovered through implementation of the intervention. So again, let's scroll down to the bottom of the tab, and you can see the results from baseline to year 1 of implementing this intervention. Again, the target population is drawn from the caseload tab. So if you change the caseload tab at all, this number will change in row 18. So as you can see, from baseline to year 1, both the intervention and non-intervention populations do gain more school days and gain more days that were previously disrupted for adult caregivers, but there's a greater recovery rate for those who participate in the intervention. So for example, for missed school days, for the cohort of 191 participants, we gained over 1,700 days, which is about 9 days per child. And then for adult caregiver days, by implementing the intervention, over 2,300 caregiver days, or disrupted caregiver days, were disrupted, which equates to about 12 days per person.
And it's more days for the adult because there are days that the kid was sick that wasn't school day, like weekends and holidays and vacations and stuff.
So to get this information, we would either decide to use published data. So again, go to the drop-down, pick published data, which would then draw data from rows 13 through 15, which is from a published study. Or you could pick my own data again, up here in the drop-down menu, in row 4, and enter your own data here in rows 9 and 10 in the pink cells. So again, if we change this to 1.5 days, that will change numbers across the table.
So it's changing the baseline, and so you'll change what you're starting from and how much of an improvement is expected from that baseline. There's a question about whether there's a way to estimate medical and social benefits past a single year post-intervention. I'm sure there is. We are limited to the studies that we found that were published, and so we're just saying, if you get the same result as this published study, this is what you would get. I would like to think that this carries forward for years to come, but I don't actually have evidence of that, so we didn't put it in the tool.
Wonderful. So let's move on to the return on investment tab. So this table estimates the potential net savings from implementing the community health worker asthma intervention over a 3-year period, and is calculated from all the data in the rest of the spreadsheet. So as you can see, based on the data we have now in the spreadsheet and the choices we've made throughout, there is a total positive net savings year over year that's been calculated, and a positive ROI year over year.
And that's because of the data that we've put into the tool. So Hawaii is a very expensive state. I think we're still on Hawaii. It has high medical costs. If you put in a different state like Georgia that has lower medical costs, this may show much lower direct medical costs. And again, if you kept the budget the same, you might show that the return on investment is negative. But even in that case, it would show you that there are medical savings that offset the cost. And of course, we have the clinical outcomes as well. I think I want to kind of move on quickly so we can get to the diabetes tool and still have some time for conversation. This last tab, other quality measures, we've just included some sort of standard quality measures that funders often use or require reporting on. If you are in an organization that gets paid more for meeting, for improvement on one or more of these measures, your finance office might be particularly interested in your solution for obtaining improvements on those measures. And then there's some more tabs at the end that I'm not going to go through. There's an appendix that has some of the data that we're drawing from in the tool, and there's some technical notes if you need those, and at the end there's how to contact us. Let's go ahead to the diabetes tool because I don't want to get too far behind. And Anit's going to come up and join us and talk about the diabetes tool. Let me just give a quick, I don't want to repeat myself too much. If we jump ahead to the intervention. So this diabetes intervention is one based in Texas that was done a few years ago. A few things that are different about this intervention than the asthma one. So first of all, diabetes, is a longer-term chronic illness that people have had poor outcomes for a long time, and changing behavior takes a long time. It's not just a medical intervention; it's a lifestyle intervention. So this intervention included. So first of all, it was over 18 months rather than 12 months, and because that's the data that we had, we did this tool over 18 months as well. So it's a little confusing when you get to the budget, because the budget is at an 18-month level instead of 12. And the other thing that's different is that it includes both individual visits and also group visits, group classes, so health education, nutrition, and exercise classes. And in the Texas intervention, those were co-taught between a community health worker and a nurse or a dietitian or an exercise instructor. So I'm going to let's just do really quick. We'll do just real quick the caseload and the budget, and then I'll hand it over. So if you go down on caseload, the top part is the same. Service time for participants. We've added a section for health education and nutrition classes. And that includes the length of the class and the time for preparation, the number of classes per participant, and then the home visits and phone calls are basically the same. And then if you jump to budget, the next tab at the top, and then go down to the first section there. So you'll see their salaries for more staff. We've included the nurse and dietitian and the fitness instructor. In Texas, the fitness instructor was actually a volunteer, so if that were the case, you could put in a zero salary there. But otherwise, this is about the same. So I'm going to hand this over to Anij.
Okay. Thank you, Katharine. I'm Anij. I'll be taking over in the Health Outcome tab of the Diabetes tool. I'm happy to answer any questions along to the presentation, and I'm also able to answer questions in Spanish if that is your language of preference. So I'm in the top of the Health Outcome Projections tab. This table projects the distribution of participants by the participant's blood sugar level, referred as glycemic level or A1C level. In the literature, it describes that having a good glycemic control is to be below 8%. Let's move to the bottom of this page. Okay. This table shows you the number of participants that goes from high glucose level to a lower level after 18 months of intervention. We define a poor glycemic level has glucose percentage greater than 9%, moderate glycemic level to be between 8 but below 9%, and good control to be less than 8%. The default distribution is using published data from a report study in Laredo, Texas, published in 2012. This study required participants to have a glycemic level of 8% or above. So we are assuming the same distribution as our projections. That is why we have 0 participants in the good control. And after 18 months of intervention, we can see that from 0, we have 117 participants in good control. And the numbers shift from poor control to a lower glycemic level. The detailed distribution is stratified by percentage in the middle of the page. Let's move to the middle of the page right here. And here is where you can enter your own baseline distribution if you have it available. So let's move a little bit to the top to change in here from published data to your own data. And let's change the numbers a little bit. So let's change this to 10. And one thing you will see is if the total doesn't add up to 100%, if it's below or above, it's going to turn in red. So let's add here the other 10. Oh, and there's one here in 4. All right, 100%. So the numbers change. in the distribution. All right.
Oh.
Questions up to here? No questions? All right, let's move to the next step. The next step is the medical cost. I'm in the top of the page. This table projects the direct medical cost for participants at baseline and at 18 months of intervention, and estimate the medical savings coming from change in glycemic control after the intervention. So here you can choose your state of intervention. Right now we have Connecticut, and this rate in here, it shows is a state comparison with the United States average. And finally, what we're going to do is here choose your 18 months of intervention period. Right now, let's pick January 2021. And that's all you have to do in this tab to get the projection. Below the cohort is going to be your intervention period. It's going to show up in here. And we are assuming your next intervention is going to follow the 18 months after your first intervention. In the participant distribution is the same distribution has the health outcomes. If you don't have any intervention, we assume the same distribution has the baseline. The cost per person is by glycemic level. And these are extrapolation of a published data from a study having medical claims in Minnesota, published in 2005. And the values are adjusted using the inflation factor reported in the National Health Expenditures. So the total cost in here is the average cost by glycemic level, adjusted by the total amount of participants in that level. If you scroll a little bit down, we have the summary. And here show the projections of total cost over 18 months, compare the intervention versus non-intervention, and estimate the direct medical savings. So right now we have that is about $1,500 per person in the first cohort. If we change that, let's change that state to see how the numbers change. Let's pick Hawaii too. Let's pick Hawaii. Yeah. All right, so we have the numbers change here. It's about $1,400. Questions in this step? No questions. Okay, let's move up to the next tab. It's the social return tab. And I'm in the top of the page. This table projects the number of days recovered at work as a result of health improvements in glycemic level and the dollars associated with it. Here you can select published data or your own data. Let's stick with published data right now. And the percentage of participants for a full-time job. So these projections are only for full-time workers. We have 55%. That is the default percentage from one of the studies that we were basing on. Okay, so I don't know why we cannot see here the wage on the page. Yeah, for some reason this is moved.
Oh, just change the.
It's changed.
Change the view.
All right. Normal. Okay. Okay, right here.
Make it bigger.
All right. All right, we're adjusting a little. Too big? There you go. All right. Okay. Right, so here we have the average hourly wage and the annual wage inflation. And you can change these numbers if you use your own data. Right now we're going to use published data, and it's going to use the mean national hourly wage right here in gray. The inflation is derived from the current population survey by the Bureau of Labor Statistics, and this is adjusted for the 18 months. and this will help us to adjust the wage over time. We scroll a little bit down. Here we have the option to add your own data if you have it. Right now we're going to use the published data, and this is the default values, and it's the average number of hours missed at work during the last 4 weeks for full-time workers, and this is coming from a study in Michigan reported in 2007. The total per person over the 18 months is right next to it, and below is the total amount for workers, the full-time workers in the A1C level category. If we scroll a little bit down, we have the summary where those hours are translated into work days lost right here, and what will be the number of days per person. We see the intervention, without intervention is the same amount, while if we have an intervention, the number of days lost at work is less. So there are 15 days recover per person. And those days are translated to dollars when we use the hourly wage. So we can see that the average for full-time worker that is recovered is about $3,000. Should we change this? Questions up to here? No? All right, let's move to the return on investment tab. So all of the values that we have in the summary tables go directly to this tab. Here you don't have to do anything, it's auto-populated. And we have the direct medical cost savings and the intervention cost. And this is going to translate to the financial return of investment. Okay. Questions? All right, let's go to the next tab. All right.
Oh, and the other quality measures again, so asthma and diabetes are two of the most common conditions for which payers include performance measures. So these are pretty standard ones. You can go down and show a few more. But particularly, percent of patients who have A1C under 8% or over 9, depending on how they count it, are really very, very, very common measures. So again, if your organization has any kind of arrangement where you get some kind of bonus for improving care in this area, it will help to offset the cost of the intervention. So that is basically it. And so we were hoping that we could have a little bit of conversation with folks on the phone. I don't know, Ellen, if you want to tell people how to unmute, or if you just want people to type questions.
Sure. So yes, please continue to type questions in the chat box if you prefer to ask questions that way. You can also ask questions over the phone, which we really encourage. And you can unmute yourself by pressing *7 to unmute, or you can put your question in the chat box. Either one will work. While folks are thinking of their questions, I have one to start us off. I was wondering if you guys could speak a little bit to what are the most common mistakes or errors that you see people make when using a tool like this, and to kind of help folks guard against making those inadvertent mistakes when they're entering data or trying to estimate savings for their program.
Hi, so this is Jeremy, and one of the things that we've seen in our use of the tool and having other people test out the tool, especially here at Shelley, is that people need to be consistent with their use of the drop-down menus. So if you pick published data, it's going to draw from published data in those applicable cells, and then if you pick my own data, you need to be sure that you enter the data that you want in the my own data cell. So that is definitely something that we've seen in the experience that we've had so far. Make sure you're consistent with utilizing those drop-downs.
Right, and if you enter data in those pink cells, that you need to choose my own data for the tool to take that data. Otherwise, it's just sitting there. So I would say that's the biggest thing. I have a question for people on the phone while you're, having looked at this and played with it a little bit, do you see that this is going to be useful to you in the conversations you have with your organizations or with your funders? Or, is there something that would make a big difference in making it more useful? I think at the beginning that people wanted another line in the caseload tool for other activities that you might want to add, and we can do that. Do you think this is going to make a difference in the conversations you're having?
We've heard from some folks already in the chat box that they're really excited for this tool, but if other folks have thoughts, please do add it to the chat box or press *7 to unmute yourself.
And another question was, I know we went through this very quickly, and so I don't know if you've had time to look at it ahead of time or play with it as we went along. Was there anything that we went through that was confusing that you'd like to hear again more slowly? I mean, we did try to get done in time to talk, but we can go back to any of these tabs and talk through them in more detail, either where the data came from or how it's calculating. Mm-hmm.
All right. Looks like someone is maybe trying to type a question for presenters. There we go. Can you guys see that on your end?
Well, I think we see first. I joined a bit late, and can we download the tool from your website? Ellen, do you want to take that one?
Yes, so you can download the tool from the familiesusa.org website if you go to our CHW Sustainability Resource Hub. We will also send out a link to this tool, and when we have the recording posted, we'll send that out to everyone who's registered as well.
Okay. Michael Chung, we see question for presenters, but not the question, so if you want to add that, we'll get to you in a minute. Debbie, I wonder what would be involved to add some of the other quality measures. If you want to send us things, the quality measures at the end was really just for to be helpful to you. These are measures that we are confident that if you do this intervention, it will affect those measures. Some of the broader ones around preventive care and screening, maybe there's less of a direct connection, but we can list them. The tool doesn't use those quality measures. We just listed them to, in case it's helpful for you to have them there. But we're happy to add more if you think that would be helpful. What other health conditions do you anticipate the tool can be applied to with currently available data? So that's a good question. So these particular models, these are very, very specific. As I mentioned, when you do any kind of a program, you generally have to do a financial analysis, but the financial analysis is narrowly targeted to what you're planning to do. And if you do something different, you're going to get different results. So these two models, these are very specific to looking at if you do an asthma home visiting program for children with high-risk asthma, in the same way that King County did their home visiting program, then we would expect that you would have results that look like this. And the same on the diabetes side. If you do a diabetes home visit program with classes in the same way that the Texas program did, then we would expect that you would get these results. So you can't actually use these models for anything else. They're very, very specific to those models. In our report that we did for the Connecticut Health Foundation, we had a couple of other models that were a little bit more general. But I mean, again, there was a specific intervention, but not a specific diagnosis. one was looking at patients who are the highest utilizers in an area, or what are now referred to as multi-visit patients, MVPs. I like that reference much better. So identifying the MVPs in your area and developing an intervention for that group. And then the other was around people who are uninsured and have healthcare needs and need help getting connected to treatment. So we're kind of hoping that going forward someone else will give us funding, or our families will be able to get more funding so we can do more models. But these ones can only be used for these very specific interventions. Sheila, can this tool be modified to the general work that the community health workers do? I mean, again, you could use the caseload and budget tools to model whatever caseload and budget you're doing, but the outcomes are very specific to these studies. Speaking of the funding members section. Yeah.
Any other questions? Remember to press *7 to unmute if you'd like to ask one over the phone.
Can you imagine using this? I'm really interested in those of you who are still there. Are you? I mean, I guess that it's fun to play with because I think it's fun. Anita did almost all of the programming of this, and every time she produced something, we just had so much fun just playing with numbers and seeing how they come through. But besides that, are you seeing applications where you could actually use this in a conversation with a funder? Oh, we got a yes. That's exciting. I'm excited that many fields will pre-populate. Yes, right. So the numbers are pre-populated to make it easy, but to the extent that you have your own data and want to put it in, great. So hopefully this will and our hope is that this is going to encourage more organizations to use community health workers for these interventions, and particularly for insurers to be more open to funding community health workers' work, because the results are so convincing.
I'm with a health plan, and I joined late, so I apologize. But I'm always asked to, what is the ROI for the community health workers that we employ for our Medicaid members? And so I sometimes struggle with kind of measuring everything that they're doing to really generate that kind of figure. I don't always have the best data right at my fingertips, but that's why I want to play with this tool a little bit to see if it can help me in that endeavor.
Great. Hope it does.
All right. Well, one last call for questions, comments, ideas, either via the chat box or over the phone by pressing *7 to unmute. All right. Well, hearing nothing, we can go ahead and wrap up and give you all a few minutes back to your day so you can go ahead and play around with these spreadsheets. I know I also have a lot of fun just inputting different numbers and seeing how different healthcare costs are in different parts of the country. That's one interesting thing you can see with this tool. But thank you again to Katharine, to Jeremy, and to Anit for putting this tool together for us. It's, I think, really useful, and we hear a lot from folks about the need to be able to have something a little bit more concrete to demonstrate, potential ROI with these programs. Again, this recording will be available after the presentation. We'll post it on our Community Health Worker Resource Hub online, and we will send it out to everyone who registered and everyone who's on our CHW Collaborative listserv, along with links directly to the tools so that you can download those if you haven't already. As always, please feel free to reach out to us at chwcollaborative@familiesusa.org. We want to hear from you. If you use this tool and want to share really something exciting that came from it, we definitely want to hear about that. If you've got thoughts on how to make it better or other models that might be useful for trying to develop a tool for, please let us know anything that you're thinking about this tool or any other community health worker issues. So again, thank you to Katharine and her team for putting together these tools and for walking us through it today, and thank you to all of you for joining us.